This is side 2 of the discussion of psychological aspects of chronic obstructive lung disease. Here is Dr. Smith.
I think for the most part, we've been talking about people who have chronic, far advanced, essentially irreversible disease. How about the person with earlier disease, the person who's not, say, end stage? At what point can you identify somebody as having definite chronic obstructive disease? I might direct that to Len.
Well, right now we can identify them when their spirometry becomes abnormal. And this is probably a medium point in the disease. This is when they have had the disease going on for some period of time, but now the FEV1, the forced expiratory volume in 1 second, is abnormal.
Could you be a little more specific? What's your usual cutoff point there?
Okay, well, in all of these tests, you have to correlate them with the predicted values for that patient's sex, age, and height, so that you really have to have a table that you look them up in. If you're talking about the FEV1, how much air the patient can forcibly expire in 1 second, then we usually express this both as an absolute value, and we look that up in a table, and we express it as a percent of the vital capacity. And usually most patients can get 75% of this air out in 1 second of the total amount that they can get out.
Like you, Len, we use a figure of about 80% of the predicted maximum voluntary ventilation is indicating that the patient has started to have some sort of chronic irreversible obstructive disease. But at this stage, it's very difficult to convince people that they should drastically modify their lives and avoid pollutants, learn good bronchial hygiene, keep up a good exercise program, stop smoking, and do all of these things that we know are going to help them. But there's no way at that point that we can demonstrate to them that it will help them. And they're not really having any particular difficulty, and they don't see any real reason for changing their lifestyles.
I understand that neither of you, unfortunately, has any program which seems to be effective in getting people to stop smoking.
I would say that's a pretty fair and accurate statement.
Don, could you give us some ideas, though, on this subject? I know you've looked at people who are attempting to stop smoking and have pointed out various types of patients in terms of their ability to stop smoking.
Well, in an ideal world, we'd be confronted with a patient who has what I would call high psychosocial assets and high intelligence. That is, this is a person who has an excellent ability to adapt to any kind of environmental or medical change and an excellent understanding of why the change has to come about. And if you're dealing with this kind of patient, your worries are over, because all you have to do is explain the situation to him, and he'll figure out a way to stop smoking. It's really not a problem. The problems come in with the people who have less psychosocial abilities, and maybe they're not any less intelligent, but they really have not learned a number of different coping abilities. They rely on, let's say, 3 or 4 main coping abilities in their lives. And if you stop one of their coping abilities, which may be smoking, they don't have a lot of alternative behaviors to replace it with. And it's very hard for them to stop smoking. It may be impossible. And you may find that they're still smoking when they're taking oxygen from a Lindy Walker or from some other source because their pulmonary disease is that bad. As a matter of fact, I recently saw a patient who lit up a cigarette when his oxygen was on and it burnt a hole in his lip.
How frustrating it is when you're dealing with one of these patients who you know has a smoker's disease. His symptoms, his disease process is really caused by his smoking to a large extent. And you're trying to work with him, you're suggesting certain things in his treatment, you're spending a lot of time with him, and he won't give up smoking. And this, for some people, becomes extremely frustrating, and in fact, some physicians refuse to continue seeing this patient who won't give up smoking. And I notice in the hospital that the hospital personnel who have to deal with some of these patients with severe lung disease point this out as the biggest factor that really makes them angry about this patient. We're suggesting that they give this patient a certain form of treatment, and they say, well, he's down the hall as soon as I'm through, and he's watching television and smoking a cigarette. Although I try and make it a strong point in every patient to support them in their stopping of smoking, I think that we have to continue to treat them just like we would any other patient and recognize this as part of his disease, that he can't stop smoking. I think we've done a much better job of this in other areas such as alcoholism, perhaps, and have kind of ignored this in some of the patients who smoke.
You mentioned the alcoholic. I was just thinking that this was very analogous to the alcoholic who keeps drinking and perhaps the obese patient who keeps eating. And I think they're all equally frustrating, at least they are to me, in that I think the common denominator is that it makes you feel very helpless and impotent, and you're powerless to do anything. The patient continues to ignore your best advice and continues to get sick and make himself sicker in spite of you, and it's really a very uncomfortable feeling.
I've treated a number of patients from physicians who will not accept patients who continue to smoke. And these patients, after they've talked to me for a while, will confide in me that they actually are still smoking. But please don't tell my doctor because I know he's going to kick me out. And they feel intensely guilty about it, and it really upsets them. But yet they can't afford to lose the contact with that doctor. And they feel that this is the only person on earth who can really help them.
I think even when the doctor isn't going to kick them out but has made a strong point about it, I think he should, that many of these patients still feel guilty because they do understand the relationship between smoking and their disease.
Your studies indicated there was no particular personality type who developed chronic obstructive lung disease. Yet, as you think about this, you describe somebody with what you called high psychosocial assets who might understand the process and stop smoking. I think I would say it would be a reasonable assumption that most of us, if we had chronic irreversible lung disease, would stop smoking. Doesn't this mean then that there might be a certain group who's selected because of some kind of a personality factor to go on and develop continually worsening and progressive disease because they continue to smoke in the face of numerous explanations as to what's happening?
I think this can be one factor, but the fact is that many people have a condition which is going to produce a severe chronic obstructive pulmonary disease quite rapidly, either due to an enzymatic deficiency or too much of one enzyme and not enough of another or whatever. And there really isn't anything you're going to be able to do to stop the progression of the chronic lung disease. So I think there's a lot of factors besides just the personality ones or just the psychosocial assets and this sort of thing. The asthmatic does not have a particular personality type connected with the disease. Instead, he has a particular kind of attitude at the time he develops his asthmatic attack. When they develop the asthmatic attack, they feel helpless, shut out, and alone. And this occurs in a setting of increasing physical and mental activation. And if it doesn't occur in a setting of increasing physical and mental activation, they don't get the asthma. Another thing that happens as they're getting activated is that they have a rise in the levels of norepinephrine, but they do not appear to have any change in the levels of epinephrine, which basically means they have a lot of alpha adrenergic stimulation and not very much beta adrenergic stimulation. If you get them activated, and if you can get their epinephrine levels to increase synchronously with their norepinephrine levels, they don't seem to get the asthma attack. Now, the asthma attack, after it's terminated, seems to be followed by a period of kind of apathy and helplessness and depression. And that appears to be when the patient gets the infection. And the infection, as it resolves, blends into another period of activation and another asthmatic attack. In some ways, I've begun looking at this process as being analogous almost to a patient with manic depressive disease, because it seems to swing. And the swings in various patients vary from weeks to months and years. Now, if you take a look at these patients from a psychosocial point of view, you find some very interesting facts. The patients with high psychosocial assets do well, no matter how you treat them in general. The ones with severe disease do well, the ones with mild disease do well. They don't require as much medication as the ones with low psychosocial assets, and they don't require as much of the physician's time. Now, the ones with low psychosocial assets or low coping ability are on a particularly bad spot because it takes a lot of physician time to help them control their disease. It takes a lot of medication. And any kind of added input, like environmental changes or psychosocial changes, tends to make their disease much worse. Now, recently we've been quantifying the environmental psychosocial changes with an instrument which gives you a quantitative value for these things. And for example, with this instrument, marriage equals 50 points, death of a spouse equals 100 points, getting divorced equals 60 points, and so forth. We're currently using 42 life event items. The patients who have high life change, as measured in life change units and low psychosocial assets, do very poorly. The patients with low psychosocial assets who have low life change do very well. The patients with high psychosocial assets do well whether they have low or high life change units. So with this particular instrument giving us a quantitative measurement of life change, we have a way of measuring the amount of psychosocial change that's actually going on, and we can directly observe what it does to the patient. And it's an interesting approach to these diseases. And this is some of the initial pilot work that was done on reversible lung disease, which is currently being carried on into the irreversible area.
I feel that has great relevance for internists and family physicians. I think it gives another very nice dimension of understanding the patient, and it gives you a way of appreciating additional psychological and other sorts of stresses that are impinging on the patient that you probably wouldn't realize in the course of, say, taking a normal history or approaching the patient in the way that you usually do. And I personally think it would be worthwhile, and we actually hope to do this in our own practice, to begin to use this as a screening device and collect this sort of information on patients as they come in on a random basis, and has certainly given me a broader appreciation of a patient's disease and so on.
It helps you to recognize certain things about the patient, and on the other hand, it helps you to deal with the patient himself more easily. A lot of the things we've been talking about are very frustrating to the physician, and I think if you can recognize these from a somewhat objective point of view, using something that Don has described, for example, in which you can actually quantify it, and it's quite reproducible from patient to patient, I think it allows you then to take another view of this patient, which is a little more objective. You don't find yourself getting quite so angry. You say, well, this explains why the patient is this way, and it also explains why I'm getting angry at him. And sometimes it helps you attenuate your own frustration and anger and be able to deal more effectively with that patient.
It is very important for the physician to get away from a lot of the traditional psychodynamic explanations for patient's behavior, because when you pull that in, or when you give that to a patient who is already struggling to adjust to an overbearing load in terms of physiologic decompensation, it's really more than he can handle. And there are ways of presenting the data now that are fairly non-threatening and neutral. For example, if you point to the fact that this patient recently got divorced, sold his house, got a new mortgage, bought a new chunk of land, moved to another city, changed his job, and you look at all those things not in terms of whether they're good or bad, but just the fact that getting a mortgage is 40 life change units, moving to another city is, let's say, 30 life change units, getting another job is 40 life change units. And then you add up all these life change units and you say, look, you've got 650 life change units in the past year. This means that in the next year, the probability of your getting sick again is about 80%. And wouldn't it be wise for you to stop some of the life change? And then if the patient says, well, gee, I can't do that by myself, then you have an opening for going into some sort of traditional psychiatric technique for aiding the patient, reducing them. But it isn't because you're confronting him with something that he did that was wrong. It's because you're confronting him with the fact that he's got a lot of life change units and really needs to stop having them.
Is there any kind of psychological factor or factors that might influence when a person goes from reversible to irreversible disease? I guess we have been conditioned to think of this as a purely physiologic phenomenon. If a person keeps smoking and the sort of physiologic deterioration goes on, then it'll become irreversible. But as you've been talking about reversible disease, I've wondered if there was some sort of psychological threshold that's passed or some psychological event or events that take place that might determine this.
I guess first I'd have to ask Len a question, and that is, in my medical education, I was always taught that reversible pulmonary disease does not revert to irreversible pulmonary disease. And I've never quite understood why the clinical teachers took that particular stance, because in my experience, patients with irreversible disease often have a reversible component, and I didn't see why that one couldn't progress to the other. But that was what I was taught.
Well, the data on that is that patients who clearly have reversible disease is their main component. So you're talking about a patient who has asthma. If you follow them on, unless they're also smoking and have chronic bronchitis and then developing emphysema from that point of view, don't seem to go on and progress and develop emphysema. In other words, if somebody has asthma and doesn't smoke, they usually don't go on and develop emphysema. And this is mainly from the best information from autopsy series. Now, what you point out is very true. What you're really dealing here with very often is a mixture of diseases. And you have somebody who has concomitant diseases, who has chronic bronchitis, who has an element of emphysema, and at the same time has an element of reversible airway obstruction, which I would call asthma. In other words, he has increased smooth muscle and has very reactive airways, which react to a number of different stimuli. And that is superimposed, if you will, on his other chronic lung disease. So that I think one of the important things in terms of managing any of these patients is identifying that portion of their disease which is relatively readily reversible and treating that very vigorously.
I'm not aware of any psychological data that will tell us which smoker will develop emphysema and which one won't. I have a very strong bias, however, which is developed out of some incomplete data, and that is that the smoker who develops emphysema is one who maintains an extremely high level of life change over a long period of time. And I don't know why that should be related to it, but that's a very strong impression that I've gotten from some recent data that we've collected.
That's fascinating. I think there again, going back to what you said, if you were collecting that data on some sort of a routine basis, you might, as you suggested, well, be able to present that to the patient, or as Len, I guess, also mentioned, and say, look, here's the data, here are the numbers. And numbers are pretty non-threatening, too. People, I think, respond much better to numbers than to other more abstract sorts of things. From the standpoint of being involved in a moderately busy office practice, we find just the vital or, which is done by our nurse in a period of a few minutes, very helpful. We do a vital capacity, an FEV and a FEF, and we have the tables there to read them. And we've found it valuable enough that we've instituted as a screening procedure so that we'd have some numbers to present to the patient to say, look, you may not have symptoms now, but you already have this number, this percent X of change, and we really think you ought to back off. And although we haven't had overwhelmingly good luck, we've had some success. I mean, it really has helped on a couple of occasions to be able to present those numbers.
Gentlemen, our time is drawing to a close. I wonder if I might summarize here. I believe you pointed out that chronic obstructive lung disease does differ from some of the other chronic diseases in the directness of the connection between emotional changes like anxiety or depression and a major symptom like dyspnea. You suggested that you can demonstrate this relationship to patients in your office, get them to experience the connection, and by making them aware of it, help them learn to control it. You've discussed the major defense mechanisms of denial and repression, pointing out that these are, to some extent, adaptive behaviors, and suggested that it's probably best not to tamper with them unless or until a maladaptive psychological reaction becomes evident. You've pointed to the importance of intervention with the family and involving the family actively in patient care and support. And you've discussed the advantages of presenting information to the patient about his disease in terms of numbers, which are neutral and non-threatening. Is there anything else?
Well, I think it's very important that we as physicians maintain a positive attitude, because the fact is we have a lot to offer these people. Even if we can't reverse the disease, there's still an awful lot of things that can be done to make the patient much more comfortable and much more productive.
The patient feels better even when their pulmonary function continues to deteriorate. He's more active. He's not afraid of the circumstances that he finds himself in.
I think you've given me, at least, both of you, a far more positive attitude about the disease.
Whether they have reversible disease or irreversible, we still have a lot to offer them.
Thank you, gentlemen. You've been listening to Doctors Donald Dudley, Leonard Hudson, and Kent Smith discussing some of the psychological aspects of treating patients with chronic obstructive lung disease. This is one in a series of programs devoted to the application of the behavioral sciences to the practical problems of medicine. It is brought to you by Abbott Laboratories as a service in continuing education under the title Mind and Medicine. Participation by our discussants does not imply, nor is it meant to imply, endorsement of Abbott Laboratories products. We welcome your comments and suggestions. These programs are produced for Abbott Laboratories by Jack Borland Associates.